Welcome, everyone. I'm Lindsay Lyon, Managing Editor at U.S. News and World Report. Thanks so much for joining us for today's webinar on the connection between housing and health, measuring community impact to ensure value. Today's session kicks off our full slate of Healthcare of Tomorrow webinars, which will explore some of the most urgent and proven solutions in healthcare. Please join us later this month for sessions examining hospital emergency preparedness, sickle cell disease, and the best hospitals for maternity project being developed by our health data team. You can sign up for those events and get updates about future programs at usnews.com/healthcare of tomorrow. Before we get started, a few quick notes. We're capturing video of today's session, which will be made available to registrants after the event concludes. Look for a follow-up email from our team. We're also broadcasting this session on the U.S. News Facebook page. If you have questions, we encourage you to please type them into the Q&A feature in Zoom on your screen. Our team will review and give voice to some of them during the discussion as time permits. Before I introduce our panel, we have a short video from our session sponsor, Nationwide Children's Hospital.
Welcome and thank you for joining us today. Our appreciation to all the panelists and to U.S. News for organizing this important discussion. Like me, you are likely here because you recognize that so much of a family's health is determined outside the walls of a hospital or a provider's office. The safety of neighborhoods, the quality of housing, access to workforce training and educational opportunities. All of those social determinants of health are crucial for our overall well-being. For today's discussion, we're focused on measuring the impact of housing on health. Here at Nationwide Children's Hospital, we've been working on housing efforts for well over a decade. Our Healthy Neighborhoods, Healthy Families initiative has helped build or repair 450 high-quality, affordable homes in neighborhoods that need them. We have clear goals and metrics for that initiative and our other population health programs, and that has allowed our board of directors to endorse and to continue to support expanding population health efforts. One of our most important goals is helping other hospitals replicate these type of efforts in their own communities. It's why we participate in events like this webinar, and it's why we created a centralized digital resource called the Collaboratory for Kids and Community Health. There you'll find case studies, research results, and resources to help support your initiatives in your own communities. I hope you'll visit the site and subscribe to the accompanying monthly e-newsletter. Again, welcome, and I hope you enjoy and gain new knowledge from today's discussion.
Now I'm pleased to welcome our guests. With us today are Dr. Dina Chisholm, Director of the Center for Child Health Equity and Outcomes Research at Nationwide Children's Hospital, Dr. Richard Cho, Senior Advisor for Housing and Services at the U.S. Department of Housing and Urban Development, Roseanne Haggerty, President and Chief Executive Officer of Community Solutions, and John Vu, Vice President of Strategy for Community Health at Kaiser Permanente. Now I'll turn it over to our moderator, U.S. News Managing Editor, Michael Morella, to begin the panel discussion. Michael?
Thanks, Lindsay, and thanks to all of you on our panel and in our audience for joining us today. We've got a lot of ground to cover, but I am really excited to drill deep into this topic of housing and healthcare. I think we could spend hours on it, so we'll try to cram in as much as we can in the next hour. I want to start by hearing from each of you just a little bit more about those roles that Lindsay just shared. John, to start with you, could you tell us about your role at Kaiser and also just Kaiser's overall investments in housing in California and across the country?
Yeah, thank you. And thank you for this panel. Thank you to Nationwide for sponsoring this. It's a great opportunity. Any chance we get to keep spreading the good word about the connection between housing and health. And I'll try to be brief here in the opening because I know we got a lot to go through. But I think, first of all, for those of you who don't know, Kaiser Permanente is an integrated health plan and care delivery system with a insurance coverage and hospital system. We cover neighborhoods ranging from Honolulu, Hawaii, all the way to Baltimore in Maryland. And we are a not-for-profit, mission-driven organization whose mission is to improve the health of our members and our communities. And we've always known about the linkage of, as was mentioned in the video, the broader issues and the broader determinants of health beyond just the health care that we provide. So we've been on a journey to figure out what are our appropriate roles and responsibilities in addressing things like economic opportunity, food insecurity, food systems, in the environment and climate and health, and then chiefly housing. So while we've always experimented with different things like in our EDs and homeless patients that we face or take care of, or housing insecure members, or the affordable housing crisis. In the last few years, I think it's just been in the headlines you all have seen. It's getting harder to afford housing. The homelessness crisis has reached a critical point, and it's just dominating our discourse. Even throughout a global pandemic, these issues still come to the forefront. So as a healthcare organization who is trying to keep people healthy, we have launched various strategies, including investments, including the role of care, including our support for community systems, which we can get to in the course of this discussion. But very much like the video, we are committed to this issue for all the same reasons.
Great. Dina, how about you next? Help us understand a little bit more about your position and shed some kind of color on those topics that your CEO mentioned in the video. Nationwide Children's, why are you investing in housing, and what's going on there?
Sure. So first, in terms of my role, I'm kind of unusual in the space because I'm a researcher by nature. I am an epidemiologist and a health services researcher, but I'm expanding that footprint to think about health services engagement in housing and communities as an exposure that an epidemiologist needs to study to understand what its outcomes are and can be. And Nationwide Children's Hospital is a great place to do just that because of what our CEO talked about at the opening video. So since really 2008, Nationwide Children's Hospital, which is located in Columbus, Ohio, state capital, a large metropolitan area, has since really 2008 been focused on thinking about how we fit into the place where we sit. So we are on the south side of Columbus, and our windows overlook one of the most challenged financially neighborhoods in our city, challenged in terms of vacancies, in terms of crime, in terms of poverty, in terms of a lot of things. And we knew that we couldn't just keep building and growing and throwing up these beautiful glass towers without thinking about what that meant to the community that we lived in. We established a program called Healthy Neighborhoods, Healthy Families. And that program partnered with the community on the South Side, a primary faith-based partner, other organizational partners, to say, how can we be part of investing in the community at the same time that we're turning parts of it into parking lots. And that has included a program that includes housing building, housing rehabilitation, and housing just minor fix-ups and cleanups to really improve the external appearance of the community. So doing rehabs that involve siding and roofs and porches, doing renovations of places that need structural change, and building things from the ground up. And then also building multifamily housing, and not just multifamily housing, but multifamily housing that has integrated career development and training for the neighborhood, for the people who live there. So it's a great opportunity to be part of changing a community, but also a great opportunity to be part of figuring out what works as we're doing those projects.
Great. Well, and thinking about what works is central to what all of you do, but Roseanne, how about community solutions? I think you work at the intersection of a lot of the community and institutional players that are involved in ending homelessness and meeting housing needs. Help us understand a little bit more about what you do.
Absolutely, Michael. We work now with 100 communities nationally to help them achieve a lasting end to homelessness that leaves no one behind. And we see the mindset shift needed to make that real is to understand homelessness as an urgent and solvable public health and racial equity problem. And that the real guiding question for us has been, how do you make all of the investments that communities make in homelessness add up to a result which is moving in the direction of what we call functional zero homelessness, where homelessness is measurably rare, that we're preventing most of it. It's very quickly flagged if a new incident of housing crisis emerges, and that it's quickly and appropriately resolved. And the exciting news is that not only is this, of course, as we're discussing, so much about improving community health, but what we have learned is that if communities look at homelessness through the lens of public health and use public health tools around collaboration, data, constant iteration and response to a changing set of conditions, and essentially form teams across organizations to tackle this as a population level challenge, not just a series of individual misfortunes, that changes everything. And we now have 14 communities that are part of the Built for Zero movement who have achieved this functional zero milestone for one or more populations. We have another 44 who are getting measurable reductions. And so very hopeful work, but it is emerging from very close partnerships with a whole range of community players, and increasingly with health systems and public health.
Great. Well, Richard, broadening out even further and thinking about your role at HUD, what's the federal government doing to address this and understand and provide solutions to this connection between health and housing?
Yeah, thank you so much, Michael, for the question and for including me in this panel. My role, my official title is to serve as the senior advisor to Secretary Fudge at the U.S. Department of Housing and Urban Development, focused on housing and services. So in many ways, my job is essentially what this panel is all about, which is to find the points of intersection where we recognize housing's essential role in healthcare. What that means day to day is really three things. One is, how are we attending to the health needs of the people that HUD assists, which has always been a concern, but has become particularly acute and of interest because of the COVID-19 pandemic, where the people who live in HUD-assisted housing tend to have vulnerabilities that make them at greater risk of both COVID transmission, illness, and death because of the fact that they have chronic health conditions. They tend to be older. They have a greater prevalence of disabilities. And we're looking at many ways, even beyond COVID, of how we're addressing the health needs of people who live in HUD-assisted housing. But second, it's also looking at how we can advance housing itself as a healthcare solution, which has already been touched on by some of the other panelists here. Homelessness is a place where it has been proven through multiple studies that the provision of housing is often the thing that makes the biggest impact on people's health outcomes, and then also can serve as a platform for the improved delivery of healthcare outcomes. And then beyond homeless populations, there's many other places where housing can be a powerful tool. There's some emerging research actually out of Columbus, Ohio, looking at the way that housing assistance can help improve maternal health outcomes and improve early childhood outcomes as well. And then the third place is in terms of my role is really to advise the Secretary on ways that we can work across the federal government with our colleagues at the Department of Health and Human Services, as well as at the state and local level, on helping communities weave together the resources that we provide in terms of housing assistance with the resources that are available in the health and human services sector to essentially provide that complement, that combined intervention of housing and services that is essentially the powerful tool to address homelessness, but so many other challenges. And so the job is about helping to break down those silos and essentially to figure out how we can help communities package together housing, healthcare, and supportive services to solve homelessness and to address the growing healthcare crises. So in many ways, the fact that my position even exists at HUD, I think reflects the fact that we care a lot about housing as a social determinant of health.
Absolutely. And I want to come back to a number of points you all made. Thank you, Richard. Let's start and with the Supreme Court. And they recently struck down the latest extension of the federal eviction moratorium, born out of the COVID-19 pandemic. That had been due to expire in October, and certain states that the rules are different. But what do you make of that situation? And in particular, are there other programs, even temporary ones, at any level of government, federal, state, or local, that can help and that can kind of provide the public health stopgap or move us toward a more permanent solution?
Sure, I can start with that, Michael. I guess I'll
Sure.
just start by saying, first of all, we find it disappointing that that was the decision that was made by the Supreme Court. The moratorium that was placed even by the prior administration, but then continued and extended by the Biden administration, was part of a essential public health kind of provision and a mitigation strategy. That we know that when people are evicted and forced to leave their homes, they end up in doubled up situations, or they end up in homeless shelters where they end up being in crowded conditions that not only exposes themselves to COVID, but leads to the kind of COVID outbreaks that harm the greater community. And I think it's unfortunate that this was struck down, because I think it's been pretty clear that the federal government does have the authority to impose public health protections in ways that really protects the broader American public. That said, our focus is 100% on trying to avert as many evictions as possible. It's worth noting that even before COVID-19, something like 3 to 4 million people were evicted in America every year. And so what we've been able to do is to stave off a significant number of evictions through the moratorium, but where now the availability of $46 billion in rental assistance, emergency rental assistance, that was provided through both a number of different bills in Congress, but most recently the American Rescue Plan, has enabled there to be resources so that landlords can be made whole, that tenants can receive the rental assistance they need so they can prevent evictions. And we hope that as many communities as possible are working to get those resources into the hands of renters and landlords so they can prevent as many evictions as possible. And also where courts can place measures where, instead of moving forward with evictions, that they ensure that people have access to that rental assistance before people are evicted. And again, I want to impress upon folks, this is not only about evictions and not only about back rent that's owed. This is about the health of the American public, that if we can prevent massive displacement of people to be placed into conditions that facilitate the spread of COVID-19, we are protecting all of us across this country. And so it's really urgent that we get that rental assistance out to communities. I want to make sure that everyone is aware that that money is available.
Roseanne, are there any examples of programs that are working, related to the moratorium or otherwise, in some of those communities you mentioned, the 14 that accomplished that Built for Zero goal? Or
well, I just wanted to underscore everything Richard said, and I think probably a larger public health message for us to appreciate in this moment is, how did we get to this situation anyway, where we have so many people in the country who are in such fragile housing situations, and that we don't have adequate housing stock, and we don't have adequate mechanisms in communities to prevent the catastrophe of eviction and everything that follows from that. So a moment of kind of profound reflection for us. I think, as Richard says, we need to get ahead of this. I can tell you at least one or two things that I think have been a characteristic of the most effective communities I've seen. But I think we should not let this crisis go to waste, and learn from it around like what infrastructure we need, so we don't have this kind of crisis befalling us when masses of people are economically and from a health standpoint displaced. I'll tell you the two things I've seen that just seem super smart, and that really savvy communities in the Built for Zero network are doing, is that they're being proactive. They're going to people who they knew had housing issues in the past, who received housing assistance, who had issues of displacement that had been resolved within the last couple of years. And they're actually going to those households to see that they're okay. They're not waiting for overwhelmed and frightened and confused folks to somehow find their way through the programs that have been set up by cities, counties, and states. And so that proactivity just is so smart. And then also, I think we've seen some of our communities, and quality improvement is a tool that we teach all of our Built for Zero communities to employ to consistently improve and tighten up and drive progress in their systems. And using quality improvement approaches to really break through some of the log jams in some of the distribution portals that have been set up. I see communities working on that to just streamline the distribution of resources. It is a tragedy that so much money both has been provided and has not been expended yet. And so that leaning into what are the system barriers is something we see a number of communities doing.
Michael, can I add a little something sort of coming from healthcare here a little bit, in addition to the urgency of the moment and what Richard talked about in terms of the availability of funds to help as a stopgap measure now. I think pre-COVID and coming out of COVID, eviction and illegal evictions was a reality for many people, and many did not have the wherewithal, the tools, the resources to protect themselves. And so there's been a tool in called the medical legal partnerships, where it integrates legal aid into the healthcare delivery process. And we've seen, I mean, it's been deployed to great effect. And what we're trying to do is now bring that into our healthcare system. We want to strengthen both our ability to identify sort of housing insecurity and these sort of legal issues that patients and members may face, and then strengthen the network of legal aid support in a community, whether it be Oakland or Washington, D.C., Atlanta, and so on, so that they can better serve all tenants in any given city or county. And then what we're hoping to do with that is launch 8 of these across 8 communities and build the cohorts where they can learn from each other, with each other, and strengthen the overall approach in the coming years here. So we're just about to embark on launching these networks of medical legal partnerships. And eviction is one thing, and housing insecurity, but once you're able to kind of have that conversation and open that up with patients, you then can identify all sorts of other issues that may require support of this nature. So it's part of a broader movement across healthcare that we're seeing, that healthcare's role in identifying these broader social health issues. But creating the systems and the infrastructure for it is the key. Otherwise, it's just one-off ad hoc sort of solutions.
Yeah, that's helpful, John. And Dina, I'll turn to you. Thinking about measuring and the data and the word quality, which it's very important in the healthcare space. How do you think about this? How do you measure success of a housing investment or a program in the community? And how do you both measure success and track it over time and communicate that within the nationwide community, but also more broadly in Columbus and beyond?
The first question you have to ask before you ask the question, how do you measure success, is how do you define success? And I think that is one of the greatest challenges as we embark on this work. So for the work we've done at Nationwide Children's in this space, our initial project was about improving the community. And we started off the first couple of years, we did a couple dozen houses, and our initial measurement really focused on things like reducing vacancy rates, reducing the number of boarded up houses, those sorts of things that didn't have a health outcome associated with them, and that were the things that were most immediately impacted by the types of work that we were doing. As we got further down the timeline, we started to think about, what is success? Is it just fixing the houses, making the neighborhood more attractive, making it more stable, reducing the crime, or as a healthcare institution, are we hoping or expecting that there's also going to be changes in health in the community? And if we think there are going to be changes in health in the community, what are they? What are the health outcomes that we really think are most likely to be improved when you're doing an intervention that involves repairing siding or repairing roofs or building houses from scratch or creating job training programs? What are the health outcomes associated with each of those? And then how do you get the data to measure it? And how do you figure out what to measure when? Some of these outcomes have a longer timeline than most of our investors and boards and others are comfortable with thinking about. So even though we've been at this for over a decade, we're starting to see the health outcomes, but we're still early in thinking about what the long-term impacts are going to be. So a lot of the measurement question is, what are your short-term, what are your midterm, what are your long-term outcomes? What are the outcomes that are most likely to be moved by the exact things that you're doing? Because if you pick an outcome that's not really related to what you're doing, and then you don't see a strong effect, it has a squashing effect on people's excitement about the work, because you say, well, it's not working. Well, that's not exactly what we're doing. Shouldn't necessarily be impacting that outcome that we're measuring. So it's a lot of thinking about what to measure, when to measure it, how to measure it, and who to compare it to. So if you're working in one community, what's your comparison community? Are you using some fancy statistical methods like we've used in our work, using propensity matching and synthetic controls? Are you trying to just do a pre-post? And what are the strengths and weaknesses of each of those methodological processes? How are you taking into account everything that's going on in the world other than what you're doing? You know, things like COVID, things like statewide investment, things like statewide disinvestment or community level disinvestment. How do you build those all into your measurement model? I say that to say that it's challenging to do, but it's necessary to do. And we're having success. In our work, we've been able to show that the community that we have been focused in has had some measurably better health outcomes than a statistically identified comparator community. Better decreases in emergency department utilization, better decreases in hospitalization over time, some small changes in community level crime, things that we think really matter. So we're getting to the point where we can measure it, but it's hard, it's time consuming, and takes a lot of thought and requires the players to come together to define what's really the definition of success.
Yeah, that seems like a very important foundational question. For the rest of you, are there other examples of, either specific data points or short, mid, long-term examples of how you measure success, how you track outcomes, that kind of thing from what you're working on?
Well, I'd be happy to describe how Built for Zero is constructed. It really is about communities that have committed to working back from a shared end state of this measurable functional zero, where homelessness is rare overall and brief when it occurs. And the first step is a community team coming together and decide that they're going to adopt that shared aim and hold each other accountable for that measurable progress. And that involves forming an integrated team, as opposed to a number of different organizations working on their own programs, really looking at the population level challenges and adapting their interventions to what will drive reductions overall in homelessness. And the second key milestone, in addition to, on top of just arriving at that commitment to a shared aim and measuring it the same way, is collecting data that is comprehensive at the population level and specific to the individual, and appropriately and actually HIPAA compliant, so very much a healthcare kind of model. Those who need to collaborate and see the same information can do so, and getting to this place where everyone is seeing the same reality and has to collaborate and creating that shared picture of homelessness in their community, with the ability to keep updating it at least monthly. And most communities now are able to do so weekly, if not daily. And then that becomes the dashboard that really guides action. If you can look at inflow differently, where are new incidents of homelessness coming from? You can ask a certain set of questions that weren't possible to ask if it was just a mass of individuals in a crisis. You can look at people who have return to homelessness after having been assisted, that something else happened there. What could be the next intervention that would be more successful? Who has returned to needing assistance after having been off the radar for a period of time, because that begins to reveal other systems that people may have been in contact with, healthcare or the criminal justice system, or attempts to resolve crises on their own. So you go from this kind of amorphous picture of an issue that has been been perceived as so overwhelming to a picture that is very actionable. And so those milestones of the shared aim, the command center, the team of teams, and the by name real-time data at a high level of comprehensiveness have been the critical milestones to get communities moving into a problem solving and kind of on the path to functional zero kind of space.
I think just to add to that, homelessness is a place where, and Roseanne's organization has been at the kind of forefront of this, of really applying that sort of population health approach to tackling homelessness, which is in many ways a housing issue, but rather than thinking about this only in terms of program administration or units created or people placed, it's really taking that population health approach. And I think it's really cutting edge. But something that we need to be applying across the board. I mean, going back to something Dr. Chisholm said, the challenge with work in the space of kind of at the intersection of housing and health is that it's often a place where we don't have great data. We don't know exactly what the health status of people who are living in particular neighborhoods are, or in housing developments are. And often people who are receiving healthcare services are not asked about their housing status or their homelessness issues. And so to me, we've learned through pilot studies, through some data linkage projects that HUD has been engaged in the past, where we've looked at Medicaid and Medicare enrollment and health insurance coverage. We've looked at healthcare utilization rates. That's what's uncovered the fact that people who live in HUD-assisted housing have significant chronic health challenges. That's what showed that there's significant gaps in healthcare access and utilization. But on a day-to-day basis, we don't have that kind of information. So one of the, I think, starting points for this has got to be how do we, break down silos, have appropriate protections, but apply a similar kind of population health approach to the way that we look at the housing programs we administer, and at the same time encourage the healthcare system to be more attentive to housing, including basic screening for housing status and homelessness, as well as even building tracking housing status into electronic health records. And there are already, in the ICD-10, there are actually codes that can be coded to be able to track people's housing status and homelessness status. Getting both the housing and healthcare systems to become attentive to, one another's sort of issues. That's how we can begin to break down those silos. And then to get to where I think the homelessness sector currently is, which I don't know that the broader public is always aware that just how data-driven that work really is, that there are attempts now in many communities, many that Roseanne organizations working with, that are trying to really get to a point where on any given day how many people are homeless, how many are being moved out of homelessness into stable housing, how many new people are entering and where they're coming from. And that's the key to be able to tackle homelessness, but also I would say to be able to tackle a lot of other issues at the intersection of housing and health. And just the last thing I'll just quickly add is, one of the places where we're looking to try to do something similar is to look at the needs of older adults who are living in HUD-assisted housing, and who for many years, the pathway has been that as people age and they're low income, so they're living in low income HUD-assisted housing, their pathway out of that is to end up in a nursing home or someplace where they're in institutional care, and where we're not providing the healthcare wraparound services that enable them to age in place. And so one of the things we're looking at is how do we look at the ways that they're already accessing healthcare services? Can we do a better job of wrapping older adults living in low-income housing with those healthcare services in ways that's more attentive to their place in their community and their housing? And then essentially bring a very tailored but scaled approach at helping older adults to age in place in our housing setting. So we have a lot to learn from the work that's been done in the homelessness space, that we could apply that kind of thinking to many other challenges at the intersection of housing and healthcare.
Yeah. And Michael, can I add one quick thing to this? I think to your measurement and success sort of question, and I'll put in a plug in here for Roseanne in feel free to chime in, Roseanne, if you want, but the brilliance of community solutions and everything Richard just talked about, they embody so well. And that's why we found them early on when we were trying to figure out what can we do to address homelessness in our communities. We found community solutions. And because of everything they do at the individual level to improve that and all the metrics for that, but this idea of attacking it at a population level, like Richard was saying, and getting that tied to improve like overall. But even more brilliant, most recently, they partnered with the Urban Institute, is that right, Roseanne, to conduct a study to think about what is and to sort of Dina's point earlier about the holistic change in a community when you actually get veteran homelessness or chronic homelessness or some big portion of the homeless population down to zero homelessness. What happens to the overall environment and climate in a community? How did the different systems talk to each other better? How does demand on healthcare go down or fire and rescue go down? How does the community experience just better quality of life in public spaces, or businesses feel like they can get more revenue because things are improving on the homelessness front? So I think that study showed, like in 4 places, I think, that you can achieve these things. And now they're going to look to advance that study even more to say, look at more specifics or improvements. But I think if people want to look at that study, Michael, that I think points to these bigger issues beyond sort of individual and even just the population level.
Thanks for the plug, John.
Yeah, Roseanne, anything you want to add to that?
Only that we have really come to see, Michael, that homelessness is such a powerful indicator for so many other things that are going well or not in a community. And if you're looking for a single indicator of well-being, homelessness could actually tell you a lot about how a community is organized to support its most vulnerable residents and to optimize its resources and to have a holistic view of health.
Great. Well, we've talked a little bit about health equity, but I really want to spend some time exploring that more. Health equity in the midst of the pandemic and what's going on still, but also as it relates to housing and homelessness. That's a major challenge, and healthcare systems, as is clear on this panel, are trying to do their part to make an impact there. Dina, could you talk a little bit about how you're doing that and how you're keeping equity in mind in all of this work in communities and neighborhoods? I want to remind our listeners, the Center for Child Health Equity and Outcomes Research at Nationwide Children's is your bailiwick. So talk to us about that. Help us understand.
We start with, a really simple definition of health equity, which is that health equity is achieved when every child has an equitable opportunity for best health outcomes. And when we say best health outcomes, that is health and well-being. And well-being goes beyond just, the absence of illness and goes further into thinking about kindergarten readiness and high school graduation and unintended pregnancy and self-harm and exposures to violence and all those things that really go into the broader definition of what it means to be a healthy child and a healthy family that it doesn't stop at the doors of a doctor's office or the doors of a hospital. When we think about housing and community specifically as one of those factors that creates health opportunity, we have to start with the recognition that we didn't get into the situation that we're in our communities overnight. That the situations that exist in our struggling communities were created. And they were created through policies that were made by our institutions. And whether that's redlining, whether that's restrictive covenants, whether that's selective zoning, whether that's driving interstates right through the middle of communities, all of those things have created the systemic disinvestment that happened in these communities that have created lower quality housing, that have created lower investments in food and in employment and in educational systems. And so to that effect, starting off by recognizing that we as a society built this mess, makes it easier to say we as a society have a responsibility to unbuild this mess. And so for every thoughtful disinvestment that happened in our communities, we have to make an equally thoughtful reinvestment to undo what's been done. And so as we think about each of these things that we're doing, each of these decisions that we're making about investment in community, picking what communities we work in, picking how we invest in those communities, is about how does this rectify the history that got us to this point? And how is this building the framework, the baseline that takes us to a better place 20 or 30 years from now? Because we're not going to get out of it overnight any more than we got into it overnight. So as a research center that is very integrated with our project and program teams, that works regularly with thinking about how we inform what we're doing based on history and based on our goals for our outcomes, we're able to say, how do we treat housing, and not just housing, because housing is part of it. Homelessness is part of it. Quality of housing is part of it. Quality of the neighborhoods in which that housing exists is a big part of it. So you can't stop at the house. You've got to worry about the schools. You've got to worry about the food environment. You've got to worry about the safety. You've got to worry about the employment options. You've got to worry about the poverty, and bringing that all together to create that equitable opportunity for best outcomes. And so that's the lens that we apply to the way we do this work, because we know we can't reach optimal health for everyone if we have whole pockets of our society that are getting lost and looked over in these processes. And those people who are experiencing homelessness, those people that are experiencing housing insecurity sometimes end up in that overlooked population. And one specific one that I want to just throw out there that we don't always talk a lot about is homeless youth. A lot of times people don't realize that shelters don't take unaccompanied minors. Most shelters don't. So if you're a homeless child, the only place you end up going is the streets or children's services. And some of the challenges in our children's services systems in this country, kids choose the street. And we have a system that makes that happen. And we have a system that doesn't have a safety net for a specific population because they say you're a kid, you should be with your parents. But if you don't have functional parents, that doesn't work. So thinking about that as one of the areas that we have put a lot of our energy as a group, thinking about how we address that challenge along with the broader challenges is important.
I'll just say, I mean, I love everything that Dina just said, and it is very consistent with the kind of things that we are being charged to do at the federal government. On day one of this administration, President Biden signed several executive orders around equity. One that, first of all, that we would stand up a COVID-19 response that includes all of the federal government, including HUD. Number two, that we would advance our COVID-19 response efforts with an eye towards health equity. And so one of the things I'm now part of is a presidential COVID-19 health equity task force as an ex officio member, where we are being challenged to think about how our current pandemic response and future pandemic responses are informed by a lens of equity. And then third, that every federal agency is charged to really think more about how we're advancing equity. And one of the things I'll just say is as a common theme, in addition to what Dina said, which is important, which is even just recognizing the history that led us to this point where we have vast inequities in healthcare access and housing access, and as Dina mentioned, neighborhood sort of disparities and segregation, is the recognition that the way that we deliver help to people contributes to that inequity, and that confronting and advancing equity means rethinking the way that we deliver help both in the housing sector as well as in the health sector. With regard to our COVID-19 response efforts, we've recognized early on that the kind of mass vaccination efforts that were being stood up were leaving behind the communities of color. They were leaving behind people who have disabilities. They were not reaching people experiencing homelessness, and certainly even people living in HUD-assisted housing who have mobility challenges, transportation issues, lack of broadband access, where a lot of vaccine registration systems required having internet, we realized we needed to take a different approach. And so we partnered with HHS on figuring out how do we essentially bring healthcare home and vaccines to HUD-assisted households. We've stood up now over 700 vaccine clinics in and around public housing settings and in other multifamily housing settings, and in partnership with homeless services providers, and thinking every day about how do we continue to do that door-to-door outreach and figuring out how do we make it as easy as possible for communities that have significant barriers to access because of distance or their own physical limitations, and how do we deliver healthcare. And I think there's broader lessons that we can draw from our COVID-19 response efforts to how we can bring healthcare home to HUD-assisted households. And similarly, in the housing sector, the way that most housing assistance is provided in America is through wait lists, through a first come, first serve approach that we know we have limited resources, that currently only 1 out of every 4 or 1 out of every 5 households who needs housing assistance tends to receive it because of the vast shortage in resources. But most of the way that we provide that housing assistance is through essentially a lottery system where anybody who's eligible has to apply, and then you sort of wait. And many people wait for years on those waiting lists. And so, equity challenges us to really think about how do we deliver housing assistance in ways that is more attentive to people who have greater challenges. And this sort of idea of a rising tide lifts all boats doesn't work. It doesn't reach people when some people have boats that have holes in them and that are sinking. And so we need to figure out ways to really bring both housing assistance and healthcare to the people who have the greatest challenges of reaching them. And so it's challenging us. This focus on equity is really challenging us all to think differently about the ways that we deliver help. And to John's earlier point, realizing that we lack significant infrastructure for the delivery of housing and healthcare, and that there's a greater attention on things like community health workers in the healthcare space. But in the same way, as going back to your point on emergency rental assistance to prevent evictions, we need to really build up a whole infrastructure at the local level for how to bring and conduct outreach to communities of color. So a lot to be said here, Michael. But one of the things I want to make sure is clear is, we gotta think about how do we bring help to people, and that means boots on the ground, knocking on doors, doing that kind of street level outreach.
Yeah, actually, that we have a number of audience questions, and that kind of ties nicely into one. What are some specific ways that the public health community, not just healthcare and hospital systems like Nationwide Children's or Kaiser Permanente, what are some ways that the public health community can specifically support the movement to end homelessness? Thinking about our audience who spans cities and rural communities and otherwise, are there some concrete examples you can point to of, maybe they're little things, maybe they're short-term things, but they could make a big difference?
I'll say some of the things that we see as most promising, Michael, include public health leaders and communities joining those common tables where the community, usually the context is something called the Continuum of Care, which is a HUD designated structure in each region of the country, that the public health leaders are now part of that team. That alone is transformational. There are a few states that have actually, at the state public health agency, created a position for someone who's the liaison to issues affecting the homeless, and that makes a big difference. It just positions those states we've seen to be ahead of the curve, and being able, especially through COVID, to get information and to roll out initiatives to protect people's health who are so vulnerable and in shelters around the street. More and more we've seen hats off to Richard here, just a tremendous partnership during COVID between HUD and the CDC, which now has a dedicated small group but a much larger working group of staff across different divisions of the CDC who are focused on homelessness. And I think this is something especially exciting coming out of COVID, that there will be a much closer relationship, I think, between not just HUD and the CDC, but I think maybe the CDC and housing entities, state level housing entities and around the country. I'd love Richard's take on that, but I think if there are folks in the audience who are public health practitioners, I would like get in touch with your COC, because it's not just that information could be shared and powerfully improve, population level outcomes, but folks working in public health really have the kinds of skills and training that is needed in the homelessness sector around population health management and epidemiology, and using kind of data to inform kind of rapid pivoting and response to kind of a changing set of facts.
Well, another, Richard.
Just kind of invoking like debate rules, since my name was mentioned by Roseanne. I'll just respond. No, I thank you for that shout out, and our partners at CDC have been phenomenal and fantastic, and I think Roseanne's absolutely right that we're seeing a kind of blossoming all over the country of public health and housing and homeless services partnerships in a way that we've never seen before, where state and local public health departments are not only aware of homeless services organizations and also housing agencies, but like have formally rewritten their pandemic response systems, the way that they operate, so that they're actually much more inclusive of that in a way that hasn't been in the past. And so and literally at the community level, you have instances of county level health, public health agencies saying, I never even knew that this thing called a continuum of care existed that organized homeless services, and that now we know about each other, but we're also ensuring that any future public health emergency responses are inclusive of homeless services in a greater way. And I think that's a great starting point for what we hope to see as a kind of transformation in the way that we respond to not only public health crises, but homelessness, where we're bringing that lens. And have it had instances where the intervention of local public health officials has actually prevented jurisdictions from doing things like clearing homeless encampments, which CDC has been clear to say, if you clear a homeless encampment during a pandemic emergency, you're disrupting the ability of people experiencing homelessness to have possessions and access to things that are actually protective during the pandemic. And so those are just a couple examples of how that has blossomed. But I think just back to your original question, what can the larger public do? I think the first and foremost thing is understand what you shouldn't do, which is that often the public's response to homelessness is say, I want to see this problem go away quickly, and I want there to be a solution that sort of gets rid of this issue, and realizing that this is something that has been built up for a long period of time, and that it stems from sort of a massive lack of access to housing, and that there's not something that will make it go away. And calling 911 or calling police or pressuring your local elected officials to solve the problem overnight leads to things that not only harm the people themselves by criminalizing them and having them involved in the justice system and having their possessions taken away, but it actually prevents the real solution, which is to help increase their engagement in the kind of services that will ultimately get them into permanent and stable housing. So my message to the public is study up on this thing called housing first, this approach that helps people to connect to stable housing, which is really the only solution to homelessness, and that figure out how you can support those efforts through your voice, through your political action, as well as by maybe contributing to some of those efforts through help with housing navigation, helping find landlords that have vacant apartments that can rent to people who have subsidies and vouchers and sometimes just don't know how to find housing.
Dina and John, a couple of questions from our audience center around how you fund these programs in your communities. Could you talk a little bit about that, and whether you're doing any partnerships with business communities and corporate foundations and so on?
So I would say that our whole approach to this work is yes and. So there's not any single stream. It started off with primarily hospital funds and funds that would be considered community benefit, but has really expanded to include a combination of LIHTC tax credit funds and bank loans and grant funding and philanthropy. We've gotten some significant funding from some major granting entities. So we've gotten funding from Fannie Mae, who's helped to support the job training component of our housing work. A lot, we've worked with the Ohio Capital Finance Group, who sort of bundled loans from a bunch of smaller banks who sort of came together to create a $20 million loan fund that has been used to, do this work that then, has some return on an investment associated with that loan. The challenge is that it's, constantly building those relationships and going after those funds and writing those grants and engaging those philanthropic partners to keep the ball rolling.
Yep, I'd agree with all that. No stone unturned, I guess, and sort of an all assets approach to this. And responsibly, given our, this is money from our patients and members in a large part. One in particular, though, that's gained a lot of traction is impact investing. I'm sure many people know about that. And that's, you're making investments in Wall Street anyways. What about taking some of those in and making investments? You're still going to get a return, like Dina said, but it may not be in the 7, 8, 9, 10% range. Maybe it's in the 1, 2, 3% range. But the social return, instead of investing in another mutual fund or a stock, investing in a loan or equity for affordable housing development, the treasury, our treasury group will still get, the finance folks will still get some of that money back. But then, what it actually affords and develops is such, so the upside on the social return is so high. And again, the beauty of that is that unlike a grant, which you sort of make and then it sort of goes away, is that this can be recycled because you start getting the money back and then you loan it or reinvest it. The other thing about this is that you asked about the partnerships and corporates and philanthropy and all that. For sure, I think any contribution we're going to make is going to be a drop in the bucket. I mean, we need billions and billions and billions of dollars here. So the next $1 million loan we make, isn't going to change the trajectory of this. But if anchor big organizations like Nationwide or Kaiser Permanente, especially in its specific community, can signal these things, be a catalyst for why we're interested, or that we be very public and leaderly in addressing these issues, attracts a lot of other players in this. One example, we kind of created a loan fund for affordable housing development. We started talking to a group like JP Morgan Chase, and then they contributed to the fund. We heard about a different fund that was starting to be created in the Bay Area in California. That an organization called LISC was working with to create for housing investments, and we joined into that, and then it grew now to $500 million based on our $45 million investment. Or public-private partnerships. The state of California governor's office took advantage of federal FEMA dollars that were coming for COVID for emergency response to direct them to acquire motel and hotel and other sorts of properties to convert them into homeless housing and longer term housing. And we contributed a bit to that. 25 million to help with the wraparound services, but that whole program reached nearly $1 billion and created 6,000 units of affordable housing in a super condensed time last year in the midst of a crisis. So it's those kinds of things that we try to keep our eyes open for, to jump in on, or start and spark and catalyze, and use all sorts of different kinds of funding vehicles to get at it.
Michael, if I could just quickly say, I love the private sector and healthcare system investment in housing, but I do want to assure you there is the federal government is not shirking our responsibility to provide significant resources to address the homelessness crisis. Right now, through the American Rescue Plan, we've awarded 70,000 vouchers across the country. In a few weeks or days, we'll be releasing $5 billion in home dollars through the American Rescue Plan. That will be another resource that can help communities to build additional affordable and supportive housing, including through the purchase and conversion of hotels that John mentioned. I also want to point out there's $350 billion that Treasury has provided in state and local aid that is not homelessness specific, but can absolutely be used as a resource. So lots of resources on the table, but great to see when private sector and healthcare organizations like Kaiser Permanente are stepping up as well.
Well, thank you, Richard. We're right about at time, but I want to ask one last question and give each of you a quick chance to respond. You know, we've talked about a lot of things: data, measurement, thinking about equity, funding. What's missing from this? You know, what's one other piece and way that healthcare providers and partners can be health forward in the way they think about housing, but also the other social determinants of health, transportation, infrastructure?
I'll just say we've learned the power of a shared aim. Whatever the question is, ours happens to be homelessness, but we are right now working in Kaiser Permanente as an anchor partner in this with the Institute for Healthcare Improvement and 5 healthcare systems and the homelessness systems, I should say 5 communities and including multiple healthcare systems in one, to really answer that question about healthcare and what are the ways specifically healthcare can contribute to transformation and outcomes for chronically homeless individuals. So there's I think also a lot of important work being done around this notion of bringing together healthcare and housing around a shared and defined aim.
Yeah, the quick thing I would say is that this just needs to become part of the norm. I'd encourage people to go look up the Healthcare Anchor Network, where healthcare anyways, as an industry, needs to think about, I've been mentioning this all assets approach a couple times, that we have so many resources at our disposal, and we need to kind of flip them and turn them inside out for greatest community development and investment. And the Healthcare Anchor Network is trying to build that movement where all health systems sort of think about contributing in this way.
I think that, we talked about it briefly, but not much, is, how do we as healthcare systems identify those at individual need when they're at individual need? So how do we have active screening and referral programs that are able to meet a person's needs when they have them, when we see them? It's kind of an inside out approach. So what are we doing inside the health system to identify and refer for help? And then what are we doing outside our doors to build the infrastructure that serves those people when they get referred out?
The quick thing I'll add to that is, we're all approaching this as housers looking into the healthcare space or healthcare providers looking into the housing space. At the end of the day, this is all about whole person needs, and that we need to understand that when we think about whole person needs, it is a combination of housing and healthcare, and that demands and challenges us to think about how we think about whole of government and whole sector solutions. And so it's a question of how do we wrap individuals who need that combination together, but do it at scale and change the way that we do things at a policy level and at a healthcare and a housing delivery system level as well.
That's a great message to end it on, Richard. Thank you so much. And thanks to our panel, Dina Chisholm, Roseanne Haggerty, Richard Cho, and John Vu. Thank you all in our audience for joining us, and looking forward to next time.